So good morning. During this session, we'll be discussing the relevant parts of the new 2020 ESC guidelines on sports cardiology and exercise in patients with cardiovascular disease and see how we can apply it to our daily practice. Why do we need the new guidelines? The original recommendations were published in 2005 and updated in 2018 and 2019. But the overarching aim of these recommendations was to minimize the risk of adverse events in highly trained athletes. However, most of the exercising population engages in leisure sports and solo recreational exercise, and unlike elite athletes, these individuals have a higher prevalence of risk factors for atherosclerosis and established cardiovascular disease. And thus, there's a need to address the issues of the general exercising population, which was not addressed in the previous recommendations. These new guidelines addresses both. And this talk has been designed to introduce you to the guidelines and present the general recommendations and help apply it to our daily practice. Due to time constraints, you'll not be able to discuss everything. We will just highlight 4 different patient scenarios and apply the guidelines. So before we continue, let me introduce you to 4 patients. Look at their profiles and, as early as now, try to provide medical advice to them on your own. During the course of the discussion, we'll find out the correct advice that we should give to them and compare the advice that you have made and see what you have gotten right. Here's Dave. He's our typical patient. He's a 40-year-old newly diagnosed hypertensive with controlled BP on meds. He's sedentary, no symptoms. He's obese with a BMI of 32. Cholesterol is 5. He's now seeking medical advice and clearance prior to starting a general exercise program and looking to do competitive road cycling with friends once a week. He's a non-smoker, same age friend just died while doing a half marathon. So his wife convinced him to consult. Physical examination and family history is unremarkable. Next is Edith. Edith is a 70-year-old female, obese, diabetic, hypertensive with CKD stage 3 and 2 prior heart attacks. The last was 10 years ago. She just had a recent heart attack 1 month ago with an angioplasty. She is currently angina-free and wants clearance prior to doing walks around her village. Her BP and heart rate are both controlled, and she has been sedentary for the last 5 years and has not tried to walk for more than 10 meters recently. And then there's Sylvie. She's a 20-year-old cheerleader who was just recently introduced to jogging. She has no cardiovascular symptoms and has been doing leisurely walks for 30 to 60 minutes on most Saturdays for the past 5 years, but now wants to do jogging 3 times a week. Her dream is to eventually do a half marathon. Physical exam and family history are both unremarkable. And finally, Raul, a 60-year-old male, non-smoker, hypertensive, and dyslipidemic retired basketball player. He has played competitive basketball for more than 10 years, but has stopped playing for the past months because of the pandemic. He claims to have no symptoms, but is mostly sedentary now and works from home. He'll be returning to work in their office soon, and friends invited him to play competitive basketball again. He had a submaximal stress test done, max at 118 beats per minute due to leg cramps a year ago, which was negative. His total cholesterol is 7, and his systolic blood pressure is 140 to 160 millimeter mercury. Think about all of these patients for now, but let us discuss the theory and evidence behind the guidelines first. Regular physical activity, including systematic exercise, is an important component of therapy for most cardiovascular disease and is associated with a reduced cardiovascular and all-cause mortality. In an era when there's an increasing trend towards a sedentary lifestyle, and a rising prevalence of obesity and associated cardiovascular disease, the promotion of physical activity and regular exercise is more crucial than ever, and physicians are encouraged to promote exercise in all patients. Although proportionally scarce, exercise may paradoxically trigger sudden cardiac arrest in individuals with cardiovascular disease, particularly those who were previously sedentary or have advanced cardiovascular disease. In parallel with the drive to promote exercise in all individuals, it is anticipated that physicians will be confronted with an increasing number of queries from individuals with established risk factor and coronary artery disease or established cardiovascular disease about participation in exercise programs and recreational sports activities. Such consultations need to strike a balance between the multiple benefits of exercise, the small risk of sudden death, and the patient's goals for cardiorespiratory fitness and ongoing participation in relatively strenuous exercise following a cardiovascular diagnosis. What, if any, are the limitations of the current guidelines? The current guidelines are the first of a kind by the ESC. Sports cardiology is a relatively novel and emerging subspecialty. Therefore, the evidence base for the natural history of disease progression or risk of death during intensive exercise and competitive sports among individuals with cardiovascular disease is relatively sparse. This is reflected by the fact that a disproportionately large number of recommendations are reliant on the wisdom and vast experience of the consensus group rather than on large prospective studies. It is acknowledged that there are inherent difficulties in formulating recommendations for all scenarios in a heterogeneous population with a diverse spectrum of cardiovascular disease due to the limited availability of evidence. Therefore, these recommendations should not be considered as legally binding and should not discourage individuals from practicing outside the remit of this document based on their clinical experience in sports cardiology. In line with good clinical practice, the present document encourages shared decision-making with the athlete or patient and respects the autonomy of the individual after provision of detailed information about the impact of sports and the potential risk of complications and/or adverse events. Importantly, all exercise prescriptions and related discussions between the individual and the physician should be documented in the medical report. Let's start by looking at Dave. He is a 40-year-old newly diagnosed hypertensive with controlled BP on meds. He's sedentary, no symptoms, obese with a BMI of 32, cholesterol borderline at 5, non-smoker, now seeking medical advice and clearance, and plans to do competitive road cycling once a week. A same-age friend just died doing a half marathon, so his wife asked him to consult, and physical exam and family history are both unremarkable. So they belong to the more than 35 years of age who wants to participate in sports. Let us look first at the level of exercise and see what he wants to do. We can use this figure to roughly quantify the exercise intensity, and we can see that road cycling is an endurance sport and belongs to the high-intensity group with a red color. Volleyball belongs to the medium-intensity group with a brown color, and competitive basketball belongs to the high-intensity group with a red color, and so on. And to identify the patient's clinical risk, we can use established risk factors such as the SCORE risk charts. There are two charts available, the chart for the high-risk regions for the urbanized areas of Europe, and a chart for the low-risk regions for the less urbanized areas of Europe. For our patients in Metro Manila, the chart for the high-risk regions will be more applicable. The chart estimates a 10-year risk of developing fatal cardiovascular disease based on the following risk factors: age, gender, smoking history, systolic blood pressure, and total cholesterol. Note the SCORE chart is for use in people without overt cardiovascular disease, diabetes, chronic kidney disease, familial hypercholesterolemia, or very high levels of individual risk factors, because such people are already at high risk and they need intensive risk factor advice. Using this, then Dave belongs to the green area with a less than 3% 10-year risk of developing fatal cardiovascular disease. So this is the SCORE risk chart for the low-risk regions, so we will not use this. Let us briefly look at this table showing the cardiovascular risk categories. So Dave belongs to the yellow color, the low-risk group. Examples of patients who belong to the very high-risk group includes those with severe CKD, or those who had an ACS, or those with diabetes mellitus with target organ damage, and so on. According to the guidelines, individuals who are habitually active and at our low to moderate risk, like Dave, except that he is sedentary, should not have any restrictions for exercise, including competitive sports. In the more than 35 years old population, more than 80% of all sudden cardiac death is due to atherosclerotic CAD. And vigorous physical exertion is associated with an increased risk of AMI and sudden cardiac death. Those who are at greatest risk are those with little or no background in systematic training. It has been theorized that increased heart rate and blood flow to the coronary arteries during exercise leads to rupture of soft plaques, causing acute coronary syndrome due to acute coronary thrombosis. Sometimes sudden cardiac arrest and myocardial ischemia can occur from demand ischemia, resulting from stable calcified plaques and fixed stenosis. In a study of US half marathon and marathon races, none of the runners with sudden cardiac arrest with serious, more than 80% coronary artery stenosis in the proximal left main or triple vessel disease. Coronary atherosclerosis had angiographic evidence of acute plaque rupture or thrombus. Sedentary individuals and individuals at high or very high risk may engage in low intensity exercise without further evaluation. Sedentary individuals and or those at high or very high risk planning to undertake high intensity exercise, as well as selected individuals planning to undertake moderate intensity exercise, should also undergo a physical exam, 12-lead ECG, and an exercise test. The aim of the exercise test is to identify prognostically important CAD and to assess the presence of exercise-induced arrhythmias. Individuals with symptoms, abnormal findings on physical examination, abnormal ECG, abnormal exercise test should be investigated further according to the current ESC guidelines for chronic coronary syndromes. Dave is mostly sedentary and wants to participate in high-intensity sports. So he will belong, you can see on the right part of your screen, for sedentary individuals and planning to participate in a high-intensity sporting event. The recommendation for Dave will be a 12-lead ECG and an maximal exercise stress test. So this is the proposed assessment in asymptomatic individuals aged more than 35 with risk factors for CV disease and possible subclinical chronic coronary syndrome before engaging in sports. If Dave has a low CVD risk and no cardiovascular risk factors and is physically active, then according to the guidelines, no further investigations are needed. Reassessment should be done if the patient develops symptoms or every 2 to 5 years for those with low CVD risk, or if the patient becomes sedentary. If the physical activity that he wants to do is only low to intermediate intensity, then no further investigation is needed. If the stress test shows normal results, then we can tell Dave that no further routine investigations are necessary to lower the risk of sudden cardiac arrest. But if the stress test shows high-risk features, then invasive coronary angiography is recommended. We can also consider a functional test or cardiac CT angiography if exercise test is equivocal or if the ECG is uninterpretable. If Dave does not want to or decides not to do road cycling immediately because he doesn't want to do the stress test and just decides to do regular exercises for now, what should we advise him? So their guidelines recommend at least 150 minutes per week of moderate intensity exercises. You can gradually increase this 300 minutes per week, spread throughout the week, that is on 4 to 5 days a week, and preferably every day of the week. Since he is also obese with controlled hypertension, of more than or equal to 3 times per week, in addition to moderate or vigorous aerobic exercise, at least 30 minutes, 5 to 7 days per week is recommended to reduce blood pressure and CVD risk. So moderate intensity can include jogging, speed walking, mid-long distance running, style dancing, etc. If Dave decides to proceed with the stress test and it is negative, and he just wants to do moderate intensity just to lower CV risk, you can also use this guide using the heart rate to control or to monitor his exertion and stay in the moderate intensity or whatever target that he wants. For example, if his heart rate max during the maximal stress test was 165 and he just wants exercises, he can use a heart rate monitor and target a heart rate of 88 to 118, that is 55 to 74% of the heart rate max during a maximal stress test or a target of 119 to 136 beats per minute for a high intensity target. Or we can also use the RPE, or the board scale, or the rate of perceived exertion. Doing a moderate intensity exercise means that the patient is still able to talk while exercising. Or we can use the heart rate reserve. So the HHR is calculated by subtracting Dave's resting heart rate, for example, 60, from its maximum heart rate at the treadmill stress test, for example, 160. So 160 minus 60 is 100. And for the moderate intensity, the percentage is 40 to 69. So we multiply 100 by 0.4 and then 0.69 and add this to the resting heart rate, which is 100. This is the lower limit of the target heart rate for moderate intensity. So we can also do the same at 69% to calculate the upper limit for the moderate intensity. So the lower limit for the moderate intensity is 100 and the upper limit is 129 beats per minute. And now let us look at Edith. She's a 70-year-old. She's a 70-year-old female, obese, diabetic, hypertensive, with CKD and 2 previous heart attacks, last one 10 years ago, and just a recent heart attack 1 month ago and an angioplasty. But good news, she's currently angina-free and just wants clearance prior to doing walks around her village. Her blood pressure and heart rate are both controlled, but she has been sedentary for the past 5 years and has not tried to walk more than 10 meters recently. Since she already has a documented cardiovascular disease and diabetes, she belongs to the very high-risk group. We cannot use the score, or we do not need to use a score chart anymore because it is only for at-risk group. So she already has cardiovascular disease. So luckily, her only wish is walking around the village, which is a low-intensity exercise. So she should still be doing exercise-based cardiac rehab at this time while doing low to moderate intensity recreational activities during the off days that she's not doing the exercise cardiac rehab. So other low-intensity exercises that she can try are the following: recreational swimming or jogging, all of which are allowed even if she's already post myocardial infarction and angioplasty. Exercise-based cardiac rehab reduces mortality, hospital readmission, and anxiety. And all individuals who just had an ACS, cardiac surgery, or PCI should be referred to an early exercise cardiac rehab program soon after discharge for 8 to 12 weeks after the cardiac event. Every week that the exercise is delayed requires an additional month of exercise to accomplish the same level of benefit. Exercising individuals with CAD may start performing low to moderate intensity recreational sporting activities in parallel with participation in structured progressive exercise programs. All types of sports activities may be considered at an appropriate intensity level. However, careful attention should be paid to the development of new symptoms. If Edith wants to try to participate in sports, she would benefit from a structured outpatient exercise program for 3 to 6 months to allow her to gradually achieve the appropriate level of activity for sports participation. If she suffered from a non-ST elevation MI or chronic coronary syndrome, but had complete revasc and did not have residual ischemia, exercise training can be progressed at a faster pace until the recommended exercise level is reached. What if she wants to do competitive sports? Careful individual evaluation is required before starting a high-intensity competitive sporting event. In competitive athletes, an echocardiogram maximal exercise test with 12-lead ECG recording or cardiopulmonary exercise training or testing is recommended for risk stratification before return to sports. CPET specifically adds information on aerobic and anaerobic thresholds guiding exercise intensity prescription and progression. But if she wants just to participate in non-competitive recreational sports and leisure time activity, similar principles apply regarding risk stratification. Symptom-limited maximal exercise should precede the return to sports. High-risk patients with chronic coronary syndromes are not eligible for competitive sports. However, low-intensity skilled sports such as golf may be considered at intensities below the angina threshold. If aerobic exercise is not tolerated, predominantly strength-related sports with a small amount of muscular work are recommended. Sylvie is a 20-year-old cheerleader who had just recently been introduced to jogging. No symptoms, she's fairly active, walks about 30, 60 minutes on most Saturdays for the past 5 years, but wants to progress to jogging 3 times a week. And her dream is to eventually do a half marathon. Physical exam and family history are both unremarkable. Sylvie belongs to the young athlete wannabes who are below 35 years old, and screening strategies must be tailored to the target population and the specific disorders with the highest risk. So sudden cardiac death in young athletes is caused by a variety of structural and electrical disorders of the heart, including cardiomyopathies, ion channel disorders, coronary anomalies, and acquired cardiac conditions. Autopsy negative, sudden unexplained death, also referred to as sudden arrhythmic death syndrome, is reported on post-mortem examination in up to 44% of presumed sudden cardiac death cases, depending on the study population. In apparently healthy young athletes, the prevalence of cardiac disorders associated with sudden cardiac death is only approximately 0.3%. And this figure is supported by multiple studies using non-invasive evaluation tools to detect cardiac disorders at elevated risk of sudden cardiac death. Thus, non-invasive evaluation tools, including 2D echoes, do not yield high levels during screening. So CV screening by history and physical examination or by echocardiogram presents unique challenges and limitations. We should be asking in the history of syncope with exertion, unexpected easy fatigability, sustained palpitations, especially exercise-induced, etc. Several studies have documented the low sensitivity and high positive response rate of pre-participation history questionnaires. And ECG typically outperforms history and physical examination in all statistical measures. While echocardiography may identify additional structural disorders, there is insufficient evidence to recommend echo for routine screening. ECG should be screened for long QT, short QT, epsilon waves, ARVC, LVH, for HOCM, abnormal Q waves for cardiomyopathies, etc. And even a normal history, physical exam, 12-lead ECG, does not say that the patient has zero risk. The patient should understand that the risk is not zero and depends on the gender, race, and even types of sports. Just to give examples, incidence rates are considerably higher in male athletes than in female athletes, with a relative risk ranging from 3:1 to 9:1 male to female ratio. So Black athletes of African Caribbean descent also have a higher risk than white athletes. And in the US college athletes population, males have had a higher risk than females of 1 in 38,000 versus 1 in 120,000 in females, and Black athletes had a higher 3.2 times risk than white athletes. Male basketball players had the highest annual risk of sudden cardiac death, 1 in 9,000, and male basketball players had a risk of 1 in 5,300. Based on the available studies and a systematic review of the literature, a general accepted annual incidence of sudden cardiac arrest is approximately 1 in 80,000 in high school age athletes and 1 in 50,000 in college age athletes. But male athletes, Black athletes, basketball players in the US, and soccer players in Europe represent high-risk groups. And limited estimates are available for youth, professional, and master athletes. So we now go to Raul. So Raul is a 60-year-old male smoker, hypertensive, and dyslipidemic, and he's a retired basketball player. He has played competitive basketball for 10 years, but has stopped playing for the past months because of the pandemic. He claims to have no symptoms, but is mostly sedentary now and works from home. And he will be returning to work in their office soon, and his friends invited him to play competitive basketball again. He had a submaximal stress test at 118 beats per minute due to leg cramps done a year ago, which was negative. His total cholesterol is a bit high at 7, and his systolic blood pressure is 140 to 160. So here's an ex-athlete who had been playing professional basketball for many years. Should we even screen him? Should he be able to handle playing basketball? He be able to handle playing basketball again? The guidelines say that we should treat him the same as Dave. He's sedentary and wants to do sports belonging to the high intensity of physical activity. So, but what if Raul is not sedentary? What if he's doing exercise on a daily basis? Surely he should still be fit. So let's check. So we first look at the 10-year risk of fatal CVD using the same score chart as we used for Dave. Since he has no overt cardiovascular disease yet, unlike Edith, we can use the same score chart that we have used for Dave. And his 10-year risk estimate is around 14 to 19%, and he belongs to the very high risk group. Despite being a former pro, Raul now has the same risk as the frail Edith. Next, we follow the algorithm. Raul wants to play competitive basketball again. This belongs to a high-intensity physical activity. So the recommendations would be the same as Dave. He's sedentary, and he wants to do high-intensity physical play. We should go through a history, physical exam, 12-lead ECG, and a maximal stress test to further risk stratify. So his previous stress test done a year ago was submaximal because of leg cramps. So we need to repeat it and do it again. There are many more scenarios that the guidelines have tackled, including specific recommendations for specific conditions, like heart failure with reduced ejection fraction or Brugada syndrome or atrial fibrillation. Please feel free to discover the complete guidelines for yourself. But the guidelines also admits huge gaps in evidence, like the threshold of lifetime sports activity for increasing the risk of developing AFib, or exercising when we have a defibrillator, or the optimal safe exercise dose in patients with cardiomyopathy. We can look forward to those in the next revision of the guidelines. Thank you.
Thank you, Paul, for that extensive discussion on the guidelines for exercise. We can now entertain questions from the floor. I see no question on the chat box, but so I'm going to throw in the question poll to stimulate the attendees to ask. In as much as exercise is really part of a healthy lifestyle, exercise when done in extreme condition, like it has some deleterious effects too. So can you expound on these harmful effects of extreme exercise? And also, can you touch on the transformation of the heart from physiologic hypertrophy to a pathologic one in people who engage in extreme sports?
So thank you for that question, Doctora. So number one, we have to understand that in the age population of 35 and above, 80% of sudden cardiac death cases are caused by a coronary artery disease. So it is understood that if you exercise, the high heart rate and high blood pressure during the exercise period increases block rupture. And this is present even if you don't have any significant CAD. So for example, you have a 30%, 40% soft plaque. If you exercise, this will not be picked up by a treadmill stress test. It will become negative. But because of the nature of the exercise, leading to high heart rate and high blood pressure, the soft plaque might rupture and cause STEMI. So that is why in younger individuals who are statin naive, who are athletes, and they are above 35, The usual presentation of a patient who collapses is actually a STEMI or a BFib leading to ischemia. So that is why it's even if you have a patient who had a negative stress test, normal 2D echo, is in the pink of health, we don't give a zero risk because there is still a risk even if the patient just has considered mild coronary artery disease. So in the less than 35, it will be a different scenario. We'll talk about that in detail later. We'll tackle the second question, Doctora. So if you have exercise induced cardiomyopathy or an athlete's heart, usually it's because of a high intensity wherein there is an increased heart rate and high blood pressure for a long period of time. So if you have high blood pressure, then the afterload will increase. Then there will be LV dilatation because of the increased LV and diastolic pressure for a long period of time. And usually the LV and RV increase. There's eccentric LV hypertrophy in contrast to LV hypertrophy caused by high blood pressure, which is concentric. And there is no test that will 100% rule in or rule out an athlete's heart. So even if you do a cardiac MRI, it can still mimic other conditions. There are clues, but the acid test for determining an athlete's heart is actually to do a detraining. So that's what we advise. So for example, in patients who present with eccentric LV hypertrophy, borderline low normal LVEF, and then an LV hypertrophy on the ECG, and then we do the imaging. They are non-conclusive. What we do is we tell the patients if they want to return to the normal LV size and geometry, they should detrain. So we usually advise 3 to 6 months of detraining, and then we repeat the imaging. If the imaging returns back to the normal or pre-eccentric LV hypertrophy state, then that is a presumptive diagnosis of an athlete's heart. So the third part is in patients who are less than 35 years old, it's not the etiology of cardiac arrest. It's not usually because of a CAD. It can still be, but odds are it's not. So it's a congenital cause. That's why the screening for less than 35 is difficult because we don't have any risk scoring for that. We just do a baseline ECG and history and physical exam. So we must understand that the guideline was made under a socialized care. So it's made in Europe. So for them, imaging tests are very expensive. That's why they do not recommend routine imaging. But again, there's a disclaimer in your practice. If you do not want to follow the guidelines, you can do so based on clinical parameters and your experience, and you can do an imaging. On a personal note, we do routine imaging patients who are high risk or we deem high risk, or who already had syncopal episodes before that are not deemed to be vasovagal and who wants to have a screening for participation in sports because it's very difficult to rule out congenital causes just based on the history and the ECG. Thank you, Doctor.
What about left atrial dilatation? Could this be a physiologic or it's a pathologic development in an athlete?
Correct,
Because
Doctor.
when you have LA dilatation, you are more prone to atrial arrhythmias.
Yes, Doctor. So left biatrial dilatation can be caused by an athlete's heart. It's the same as having high blood pressure. If you do the exercise repeatedly, your blood pressure will increase for a long period of time and can cause left atrial dilatation. So we'll touch on the atrial arrhythmias now. So in general, if you're a competitive athlete and you want to participate in sports, there are two classes of drugs that are contraindicated. So they cannot take beta blockers or diuretics. So because in the anti-doping laws, they're usually detected by the urine test and blood test. So if you have a patient who has a dilated LA and has a documented atrial fibrillation and he wants competitive sports clearance, you have to advise that particular patient that if he or she takes a beta blocker or a diuretic, then it might be picked up on screening and he or she might not be allowed. And of course, we know that beta blockers also negatively impact sports participation capacity. So if they take on beta blockers, generally they usually feel weaker and they may not like that. So if they have an atrial arrhythmia and there's an increased risk for stroke and you put them on a blood thinner, then of course the question of contact sports is again discouraged. So patients who are on a NOAC or warfarin are discouraged to participate in contact sports for fear of causing bleeding, significant bleeding. And of course, if you have an atrial arrhythmia and you're at increased risk of bleeding, and the patient does not want to take blood thinner, then the risk of stroke will be high. So that will be his or her personal decision. In patients with atrial fibrillation who are very symptomatic, what we usually do is to do and who do not want to take antiarrhythmic for a long period of time because of side effects. There are some physicians, including me, that we do elective cardioversion to convert them to sinus rhythm during the time that they want to participate in sports, and then they will just periodically check their pulse and see if they go back into AFib. So those are for patients who are very symptomatic. They can feel their AFib coming in and who do not want to take in antiarrhythmic. So, but in general, if the AFib is okay, controlled, patient is asymptomatic, it's just the LVEF is okay, then it's not really a contraindication to sports participation. The problem then is measuring how much the patient's exertion is. So we cannot rely on the maximal heart rate or heart rate reserve because the ventricular rate is variable. So what we do is we rely on the Borg scale, the RPE, or rate of perceived exertion. So that is which will guide us regarding the intensity of the exercise. Thank you, Doc.
Thank you, Paul. Dr. Bernardo has a question. Is there a genetic predisposition to an athlete's heart?
There could be, Doc. So, but there's no actual evidence that that will say for certain that there is. So, but personally, I believe that there is a genetic predisposition. But as of now, we don't know exactly the exact gene or how. Even if we do know that, there's no way to mitigate it except for detraining. So, for example, if you have an athlete's heart, that you have a genotype, it doesn't follow that you will have a phenotype. So that's the main problem. So that's just like in long QT, even if you have the genotype, you have the gene, it doesn't follow that you will have the phenotype, the actual sickness. So that's the problem.
Another question from Dr. Andrew Prieto. Can diastology and 2D echo distinguish athlete's heart from hypertrophic cardiomyopathy?
Yes, Doc. So actually, there are different parameters on the echo and the cardiac MRI that can distinguish both hypertrophic cardiomyopathy versus this cardiomyopathy, LVH from high blood pressure versus an athlete's heart. But it's not 100% specific. So the only certainty is that if you detrain, so if, for example, if it's hypertrophic cardiomyopathy, it will still be there even if you detrain. If it's because of high blood pressure, it will still be there even if you detrain. But if it's an athlete's heart, usually it will go away when you detrain. So there are parameters that you can look at, but they are not 100% specific.
Another question, and an interesting question from Dr. Lapitan. What's your take on a young active male with occasional PVCs with is this no structurally normal with a structurally normal heart on echo and treadmill stress test showed disappearance with increasing exercise. Would you treat the PVCs? Would you clear him for a 42 kilometer run?
Thank you, Doc. Thank you for that. So in the 2020 ESC guidelines, actually their threshold for PVC investigation is very, very low. So if you have a 2 PVCs on a baseline ECG, or if you have one greater than or equal to 1 and you're an endurance athlete, then that already warrants an investigation. So we have to understand that the PVC burden, the number, is not usually prognostic. So the more prognostic is the presence of an structural heart disease. So what we usually do is, as Dr. Lapitan already alluded to, we look at cardiac imaging to see if there's a structural heart disease, a Holter to see if there are complex ventricular arrhythmias. So, for example, NSVTs or polymorphic ventricular tachycardias. Then they are more prognostic. So, but the presence of a PVC in itself is not prognostic. So, when to treat? So, there are two parameters wherein we treat. Number one is for symptom prevention. So, if the patient has a structurally normal heart, no fibrosis, no scar on imaging, and the patient is not symptomatic, then you don't have to treat unless you want to prevent what we call an arrhythmia or tachycardia-induced cardiomyopathy. So this is a topic for another lecture, but in general, if the patient is symptomatic, you may give, but the first line of treatment is usually a beta blocker, and if the patient wants to perform well or is participating in competitive sports, then usually a beta blocker is something that they don't want or is not preferred. So in that case, you do not need to treat if the patient can be advised that it has no increased risk for sudden death, and if there is a low risk for tachycardia-induced cardiomyopathy. So for the tachycardia-induced cardiomyopathy or arrhythmia-induced cardiomyopathy, we can use the Holter to predict. So there are a lot of different opinions. Some authors would say that the PVC burden of more than 10, 15, or 20 confers an increased risk for tachycardia-induced cardiomyopathy. But again, those are just small studies. They're not randomized controlled trials, so we do not know. So, but in general, if the patient has no structural heart disease, no symptoms, just PVCs, and disappears with exercise, so it's not an adrenaline-induced PVC, then we follow the guidelines. We look at the CVD risk. So, and then if there's the CVD risk is less than or equal to 5, and then we look at the intensity of the activity. So since the intensity of the activity is very high, then we should still interpret the exercise test. So if the exercise test is maximal, then the patient should follow the maximal heart rate on the exercise test and should not exceed. So we advise the patient if they're able to reach 160 beats per minute on the exercise test, then it is they are not tested above 160 and should not exceed. So we can clear him, but under those particular scenarios. And then, of course, we need to tell all patients, even if you clear, it doesn't mean that the risk is zero. It only means that the risk is low. So we never tell patients when they ask, is the risk zero? So we don't. We just tell that the risk is low, and for the guidelines, that's the only thing that we need to tell them. That the risk is low, is still there, but it's their decision to participate in that particular sports activity.
A question from Dr. Oliver Sansano. Are patients on anticoagulant, warfarin, or DOACs be allowed high-intensity exercise?
Yes, Doc. So the only contraindication based on the guidelines to blood thinners is actually contact sports. So even if they are on a blood thinner, if there's no risk of contact, then it's not a contraindication. But if the patient is participating on a low, for example, just friendly basketball, but there's contact, then that's when the risk of hematomas, bleeding is high. Of course, if there's a risk of falling, so for example, it's a low intensity like tightrope walking, but there's a risk of falls, then that is also part of the guidelines. They should be discouraged from doing that because if they fall and they can suffer a intracranial bleed, then that is also bad.
From Dr. Aguirre, there are reports of sudden death while doing exercise or running in apparently healthy athletes or those who are physically fit, but they lack sleep. Please comment on this.
Sorry, Doc. Sorry again. Sorry.
There are reports of sudden deaths while doing
yeah.
exercise or running in apparently healthy athletes or those who are physically fit, but they lack sleep. Can you comment on this?
Okay. So difficult to comment. That's not part of the 2020 ESC guideline. But anyways, again, the even if you're healthy, the risk of sudden cardiac death doesn't depend on the healthy status of the patient. So why? Because even if you're healthy, if you go back to the guidelines, they mentioned that those patients. I'll also answer the question of Dr. Bernardo. Why are players or basketball players at high risk for developing cardiomyopathy? It's because it's not the fitness of the intensity of the exertion. So again, even if you have a 10-20% soft plaque, if you do marathons or if you do basketball and your blood pressure increases to 200, blood pressure increases, then the chance of that plaque rupturing is high and can cause sudden cardiac death due to a BFib or STEMI. Lack of sleep. Yeah, lack of sleep can cause problems. I'm not sure if you're just Dr. is just talking about standard lack of sleep, but if it's caused by, for example, sleep apnea, so that then the patient will have an increased sympathetic tone upon waking up, then that is a risk factor for arrhythmic death. So, but I haven't read of any study wherein just plain lack of sleep can cause cardiac death. But the general statement is that even if you're very healthy, there's no guarantee that you have 0% chance of developing a cardiac event. But what we're saying, or what we should be explaining to the patient is that the risk of cardiac death is lower compared to the benefit if you do a low to moderate intensity exercise. But if you do a high or competitive sports, then it depends on the scenario. So if you're doing competitive sports, it's very difficult to hold back. So for example, if you're playing basketball, you cannot tell yourselves that I'll just play 60% of my maximum. It's very difficult because there's a competition. You're driven to perform better. So that is when the problems happen. It's because of the competitive drive. You overexert, and then that's when the increased risk for sudden death happen.
Question from a guest, a friend, Dr. Delta Canela. Welcome. What is the risk of taking energy drinks by athletes during exercise or competition?
So there are two types of drinks. One is the ionic drinks, or those that replenish the lost nutrients and electrolytes, and one is the energy drinks, those that contain stimulants. So of course, caffeine. Others are known like catecholamine-like agents. So if we're talking about ionic drinks like Gatorade, then they're not usually associated with the increased risk of sudden death. But if we're talking about energy drinks that contain like caffeine-like substances or catecholamine-like substances, of course, catecholamines or caffeine can increase the chance of an arrhythmia, irritate the heart, and of course, if you're taking in caffeine and you're not hydrating adequately and you're sweating a lot, then you're also prone to having dehydration. So it has been theorized that, of course, if you take in a stimulant and you're also adrenaline loaded because you're exercising, then there's an increased risk of an arrhythmia. And that arrhythmia, if you're dehydrated, outcome. So in general, we do not recommend that athletes or any individual take caffeinated or something that will give them an energy boost. They're also illegal in most sports because of the risk of arrhythmias. So even if you have a healthy heart, you take a lot of caffeine, you'll develop AFib. And of course, if you have that during a sports activity, then it can lead to a sudden death.
Thank you, Paul. I guess the take-home message here is let's all exercise, exercise safely. Beyond what is healthy, we should not. So,
Yes.
thank you, Paul, for that comprehensive lecture on sports cardiology and the guidelines.